So hi, it's great to be here. I'm Daniel Kraft, and I'm going to speak probably way too quickly in the next 15, 20 minutes. And I thought what I'd cover is, you've heard a little bit about some really exciting work going on in the Netherlands, and we'll touch on that, but kind of want to impart a bit of a frame shift into your thinking about where technology is integrating to affect not just therapies in terms of treating cancer, but also other elements in terms of wellness and prevention. And that crosses a large spectrum from what I'll touch on in this brief talk. And obviously, whether we're in Europe or here, there's a lot of big challenges in healthcare and medicine. Clearly, the costs are becoming a big issue. At least in Europe and the United States, we have an aging demographic. There are about 10,000 individuals in the United States turning 65 every day. How we access care is a big debate. A big issue, I think, that will be affected by the technologies we just heard about in the last talk was the variations in clinical practice. Why do we treat, let's say, every lung cancer patient the same? Maybe we're going to start to dig into better ways to do that. We often don't even use the information we have. The information we have is scattered in different places, and there's a lot of waste in the system. And finally, even though some of these technologies we are hearing about and that I'll talk about are very exciting, and even many of them are here today, there's this very complex regulatory landscape that we have to meander through that can often delay things by often decades, and that needs to evolve as well. So just a couple of framing issues. Obviously, chronic disease is a larger and more pressing issue, especially in the aging population. So just that's ramping up. We, at least in the United States, waste a ton of money. A large fraction of the healthcare dollar is not really used to treat the patient, but is lost in paperwork and billing, in administrative inefficiencies, repeated tests, and that can certainly be improved partially by putting together in a smart way systems and technologies. And while we're talking about the genome and sequencing, a lot of what happens in healthcare really isn't from our genetics, it's our behavior. And how can we potentially use technology and even basic behavioral modification to improve health outcomes? So that we really start to move this curve to the left, because most of what we're spending our dollars on are kind of at the end of life or in patients with chronic disease like diabetes, so that the bulk of our healthcare dollars ends up going to a relatively small percentage of the population. And if those dollars, for example, spent on treating renal failure or heart bypass were moved up front, that could be quite effective. The challenge we have, especially in the States, is that the incentives aren't aligned to make that happen. Clinicians, and I've trained in primary care as well, don't get paid usually to keep people healthy. We get trained to put the stent in or do the bypass or put in the pacemaker. So, but I think it's a really exciting time right now in not only healthcare and medicine, but across multiple technologies. And putting these things together, I think, is where it gets to be really exciting. And I think many of the people in the room are working on some of these things. And I'll cover these in my short talk, hopefully, and put them together. So the first context I want you to think about is the term exponential growth. So we tend to think kind of linearly, that technology sort of plods along in a stepwise fashion, but really in many areas we're in an exponential age where things are moving very quickly. The most common example of that is Moore's law and how much computational speed we can fit in. One example that I stole from a friend of mine is that if you have a lily pad and you let it divide every day, it goes from 2 to 4 to 6, 2 to 4 to 8 to 16. By 10 days you're at 1,000, 15 days you're at about 32,000. So anyone can tell me where we'd be at a month? Anyone quick? So we're at 1 billion already. So that's exponential technology. So I could take 30 steps, I'll be across the room. 30 exponential steps, I'd be around the world several times. How many times, Raymond? I can't remember. 4.5 times. So that's thinking exponentially. And one of the my favorite example you all have in your pocket is that of the mobile phone. It started off stepwise, moving forward, and then all of a sudden, wow, we have this new technology. And that wasn't so long ago, right? That was Wall Street 1, the movie 2. Now we're at Wall Street 2. It just came out. And now we're obviously in the age of the mobile smartphone. And it was 4 years ago today that the iPhone came out. So to set your clock a little bit. And now we're already at the iPhone 4. And that's obviously a lot better than the iPhone 1 if you had to go backwards. And now we have Android and other platforms. And so you might wonder what will happen when we have the iPhone 6 and the iPhone 8. Just think of all the things that have happened with just mobile. I've been involved in starting to think about this technology, helping guide the medicine track in a new program that's held down the road about 30 miles south at NASA Ames called Singularity University, which is co-founded by Ray Kurzweil, who's a pretty well-known futurist and inventor, and Peter Diamandis, who was the founder of the X Prize. It's done, Spaceship One and others. Ray McCauley, who's over here, is actually the chair of the biotech track, and so we work closely together in this program, and it brings together every summer about 80 really smart students. I mean, they're not really, they're really participants. The average age is around 35, from all different spectrums, who might be good nanotechnologists or bankers or lawyers or doctors, and cross-trains them in these different technologies, from artificial intelligence, robotics, nanotechnology, medicine, biology, law, space, IT. And for 10 weeks, people get together. We have some of the best folks in the world coming through, and people get to learn about what are things at the cutting edge and where are they going on these exponential curves, and how can we put those together to address major unmet needs, from global health issues, poverty, energy, waste, the environment. So it's a really exciting place. The program just started, and it's a real fun place to be. It's got several big sponsors. We just put together a one-week program about a month ago, an executive program called FutureMed that Raymond also taught at, where we looked really at where medicine is going and where technology is taking healthcare and medicine. We'll do another one in early February, which you should all come to. And as Singularity U also does these one-week executive programs, which you might want to come to as well. So if you don't have 10 weeks, you want to come together and learn some of this, it's helpful. So briefly back to the phone. The phone, in a sense, is becoming a medical device. And that really almost started in the developing world. So Africa, for example, South Africa, the mobile phone is the medical record. It's the way of texting and getting information back and forth. Now we have, and the bottom billion, by the way, all have mostly SMS smartphones. Now we're on the era, they have SMS text phones. Now we're in the era of smartphones, at least here, and they now have, since that iPhone came out 4 years ago, there are about 20,000 different applications that can apply to health, from tracking your running, to tracking your pill ingestion, to helping make decisions. There are chips and small microfluidic chips that are now being integrated with iPhones. This one was developed in Europe to test for STDs, so you can pee on the chip and get a result back right away. Timely manner. There are maybe more commonly used examples, so those folks with diabetes and checking their blood sugar and usually scribbling the numbers down and can't keep track. Now that can be integrated, in this example, with an iPhone. And that data can then be seen by the patient and understood, and also shared with their, let's say, endocrinologist or with their mother, and they can start to adapt these. So mobile devices merging with diagnostics in the mobile setting is becoming important. So in the rest of the talk, I'm going to kind of cover where some of these trends are going. So we mentioned in exponentials, one of the biggest examples is Moore's law and computational speed. So computers are getting faster and faster, approaching in some level or surpassing in some levels that of the human brain. So we can do some things with computers obviously better than we can, play chess. Eventually we may be able to upload and download information. But where I think faster speed is most evident, and we just saw examples from the prior two speakers, is that of imaging. So now we can look inside the body in real time. This is fMRI. So in this case, the heart is baggy and not pumping well. The patient's in heart failure. That's one example. And now we're having a higher and higher resolution, and we're combining, as we heard from the first speaker, molecular diagnostics. So not only can you see the anatomy, but you can pick up, for example, a tumor at much higher fidelity, track that with different labels, see the activity, learn whether it will respond to rituximab or other potential therapies. So those are layering together. And as we get better and better resolution and better speed, we can start to do really interesting things. This is a really very high, this took a couple days to process, it's getting faster. This is a high-speed reconstruction of my friend Mark's brain. And not only can you appreciate the amazing anatomy, but now we can start to see the connectome, so the interconnections of the brain, the pathways, figure out what's normal, what's involved in depression or schizophrenia or bipolar disease. And in some cases start to reverse engineer neuroanatomy to maybe build smarter computers as well. So resolution is coming down in terms of price, in terms of faster speed, in terms of more data. Eventually, I think, in terms of personalized medicine, we'll start to image people's brains and see how they respond almost in real time to, let's say, an antidepressant, and be able to pick those in a better way, as opposed to today where it's sort of one size fits all, and it takes months to tweak certain medications. And the scanners themselves are getting smaller and more portable, not necessarily cheaper yet, but they're becoming more plentiful and easier to pull into an emergency room, for example. And now it's almost a problem of too much data. So the scan of today is about 20 gigabytes. That's 800 phone books, just to put it in context. And now with higher resolution, higher speed scans, we're getting to the era of terabyte scans. So it's a ton of data. It's mostly going to the cloud, and it's almost a challenge to be able to look and understand that data. One example of how that's starting to impact clinical trials or clinical work today, which is starting to become practice of care. Instead of going for your sort of pointy end colonoscopy, which most people want to avoid, we're going to the era of virtual colonoscopy. So replacing the uncomfortable method with just a CT scan. You can see the virtual colonoscopy looks similar to the actual. And so this is a screening test, but now the radiologist can sort of fly through the colon, and by leveraging on top of that artificial intelligence, maybe detect lesions that might have been missed by a radiologist in a normal way. So you see that one was picked up, for example. So it's merging a couple different technologies together. We can also do virtual angiograms. There's a new company that spun out of Stanford called HeartFlow. They take the data from a fast, rapid CT scan, put it up in the cloud, and they can reconstruct the blood vessels of the heart, and not just the blood vessels, but do the very highly computationally demanding fluid dynamics, and look at each blood vessel and determine whether you need a stent or not, or what would happen once you put a stent in there. And so this will keep a patient from having to get the wire up and the dye and the actual interventional procedure. I think it's going to be a game changer as one example. So we can simulate there. We're starting to use simulation in the field of medical training. So that was mostly started in anesthesia. So just like we use flight simulators, there's now sort of medical simulators. So rare events that might happen in 1 in 1,000 patients can be simulated, for example, in the anesthesia suite. And so if that comes to happen in real life, just like the pilot, they're much more prepared for the emergency. And we can train and simulate surgeries and layer on technologies into that. At Stanford now, all the medical students get iPads. Their entire curriculum's on an iPad. They have a new sort of virtual dissecting table. So while we still have real cadavers, you can do a sort of a virtual dissection. So that's the integration of imaging and speed and computation. What I like to call this integration is a real paradigm shift of digital medicine, essentially pulling together the integration of biomedicine, biomedical data, IT, wireless communication, and I think mobile, which all fits into that together. And that's really going to start, it's just starting to change the game of medicine. So, one example is that my stethoscope today is now actually digital, and I can plug that into an app and listen to the heart sounds and actually record those and help, most physicians are terrible at doing heart sounds anymore, and currently, but now I can actually look at that and share that with a colleague, and they might be able to help in the diagnostics. We're moving to the era of smaller, cheaper diagnostic imaging devices. This is the old Star Trek tricorder. I just spent a day last week with the X Prize Foundation. They're doing an X Prize to create the next tricorder, in a sense, which may be similar to current devices. That's now a $3,000 or $4,000 handheld ultrasound that is replacing essentially what used to be a $200,000 device and can be used in the field or in an ER. This is the one that's out by GE about a year ago, so handheld ultrasounds. So eventually we'll get to these sort of more integrated tricorders that maybe if we layer on artificial intelligence and other elements will be quite powerful. The other element in the era of digital health is that we're moving to electronic medical records. I know in Europe we're pretty far ahead, but in the States we're still just moving to what's called the EMR. But now that the data is starting to be captured, it gives us the opportunity to look at that and crowdsource it and understand it in different ways, even though there are challenges from HIPAA and compliance. I can use other apps to look at data from a patient in the ICU or in the obstetrics ward. So the ability to access not only the patient's data, but for the patient to access their own is becoming pretty important. And clearly with the iPad type technology, that's becoming quite ubiquitous across the wards now. A lot of actual, from radiology to databases are being shared in that way. You may have heard in the news about, 3 months ago, IBM sort of tested out Watson, their big AI system, against the 2 champions in Jeopardy, and it beat them. And now they're actually turning their attention to medical AI. They're putting Watson to medical school, and apparently he's at 2nd-year medical school level. And so, now you don't need to have this in your back office. You can access potentially Watson from the cloud from your smartphone. So I can put in, a random array of clinical findings, and potentially Watson could help me make the diagnosis. And I think that's going to really be a powerful agent, particularly in areas where there are not enough clinicians or not enough fully trained clinicians. This sort of information is going to become more relevant. I can visit my doctor now, sort of telemetrically. Skype type sessions are being done and set up where you can visit sort of online. Cisco has a very complex health presence system where you can do very detailed exams and look through the ear and look at the skin through these sorts of telepresence systems. But you don't need to be fancy. You can, again, use your phone to do basic, my friend here sent me a picture of her cut. I can help make a diagnosis and keep her from going to the ER. We might be able to use new technologies like the Microsoft Kinect to diagnose, for example, stroke by measuring motion. There's a new app that just came out this week called Skin Scan, where you can scan your skin lesion if you think it might be melanoma, and it analyzes it in the cloud and can tell you it looks like it's low risk or high risk. It might then tell you where your local dermatologist is and if you need a checkup. So this is an early example of disintermediating maybe dermatologists from a very common thing they would see is if this proves out to be really accurate. So virtual dermatology. How about virtual pediatrics? If you have kids and you're sick of sending them to the doctor with an ear infection, there's a group here in San Francisco called CellScope that's building a connection for your iPhone again that can look in the ear and telemer that data back to the pediatrician to make some choices about whether you need to send your little kiddo in from school. And eventually, we're starting to merge telepresence from the phone and the handheld to robotics that can visit you in the hospital. If you want a specialist to round in Amsterdam who's from UCSF, that kind of thing can happen, is starting to happen. And there's a whole slew of devices that are moving to the home to start measuring things. The basic measurement device used to be the scale maybe and the thermometer. So now we're integrating electronic thermometers, electronic scales, electronic blood pressure cuffs that can pull that data together and share that with your doctor or the nurse practitioner and keep people at home healthier, hopefully healthier and better. Again, I'm not a salesman for Apple, but there's so many cool things coming out that people are making themselves. So this is a device, a case the guy's built on. He's an ER doctor. Slide it on the iPhone, you put it on the chest, and you can get the EKG. So maybe if you have this at home and you're having funny heart rhythms, you could use something like this. So they're trying to commercialize that type of technology. So a lot of creativity is going out there. This used to be the way we would do a Holter monitor, not the most elegant procedure. A colleague at Stanford has a spin-out company called iRhythm, which is changing the way we do diagnostics in cardiology. You put that paste on your chest for a week, then you drop it in the mail, and all the data comes back to the cardiologist within a day or two. Eventually, that'll be all through the cloud as well. There's a whole new movement that was started in the Bay Area called quantified self, meaning to look at yourself and quantify it from people who wanted to measure everything about themselves, from sleep to how far they run. Now, in the last 1 to 2 years, there's many devices that are being sold for about $100, like the Fitbit, which you can wear and measures how many steps you take, monitors for sleep. Down the street, there's a company building a watch that has a pulse oximeter in it and a heart rate monitor and motion detection. So that whole movement of what's quantified self is coming together to allow you as the individual the ability to look at your own sort of dashboard and make some decisions about your health and wellness. And those are going to get more complex and hopefully more integrated. Right now, those are sort of different data streams, but they're starting to be put together into one, let's say, dashboard. As those come together and we can learn more about that data, it'll be more useful both in prevention and therapy. So I'm talking way too slow, so I'm going to speed up a little bit just to say that these devices are shrinking and moving into our systems, and eventually, just like our cars measure our system, I think we're going to see these sorts of devices, ubiquitous monitoring, not just of our vital signs, sort of everywhere. And you might subscribe to a service where eventually you check into your mirror and you get some feedback in the morning, or you can check into your kid's diaper via Twitter. So those are some possibilities. But a lot of this doesn't need to be high tech. Thomas Getz, who's the editor of Wired, has shown beautifully that this is the standard lab result. You can just take some nice design result, instead of taking these basic kind of ugly things that no one can really understand, make them beautiful, integrate it, embed that with information, and that gives the patient and the doctor a much better sense of what your level is, where it really means, and how it's relevant to you. So not everything needs to be high tech, and there's lots of ways to improve user interface, for example, just for data. Simple things are going on in the operating room now, like checklists. So, yes, you want that leg, not the other. You don't want to be surprised afterwards. And so checklists, just like in flying, are becoming the norm, especially in the operating room theater. And I think sort of these technologies, while exciting, can hopefully enable the doctor-patient relationship to get better. All right, so quickly into some other technologies. Robotic surgery, it's already here today, and it's getting more exciting because new technologies are layering on top, like augmented reality. The ability to see where the blood vessels are and the tumor might be are sort of in development stages with companies like Intuitive Surgical. A surgeon here can be mentoring a surgeon in Europe and looking at the same patient through their scope. We're starting to enter the era of sort of scarless surgery, where the robotic endoscope will come out the stomach, for example, and pull out the gallbladder. That's called NOTES. So as the devices get better and faster, right now the surgeon's still doing this to the procedure, really, through the robotic endoscope. That's going to become more interesting and exciting. And we're going to start not to just to connect the surgeon through robotics, but paraplegic patients, for example, or quadriplegic patients, where several groups, including at Brown University, my old alma mater, have developed a brain chip that can go on top of the motor cortex and allow the patient, just by thinking, to move a robotic arm or a wheelchair or a cursor. That's now being integrated with like robotic limbs, such as the one that's been built by Dean Kamen and his colleagues. So I think there'll be an integration between brain-computer interface and other sorts of devices like these limbs. And in the end, we can pull these together. It doesn't have to be brain-computer interface exactly. You might have weakness in a leg, for example, or be a paraplegic who can't walk, still can use your upper limbs. Now you can actually put on external robotics and walk. And this is across the bay at Berkeley Bionics. This gentleman has been paraplegic for about 3 years from a motorcycle accident, and now he's essentially walking with the use of an exoskeleton. It's still in development mode, but this is really important to them psychologically and otherwise. And I would predict in 10 years you'll see consumer versions of these devices out there, even for folks who've just had strokes or the elderly, to help them get around. So, other trends in medicine are clearly cost and size, but in the trend overall is to get smaller. We can build smaller devices. They can move through the body in different ways. They're implantable, swallowable pills that can move through the GI system, and those are getting smaller and more capable as we can shrink more in small places, to the point where I think you'll see these sort of autonomous little microbots that crawl through your system. They're kind of scary looking, but they're already well underway in terms of clinical trials, and these little micro robots might even self-assemble in the future, put them together. I'm going to skip a couple of these just to say that things like pacemakers are getting smaller and more able, and they talk to your phone, so you can analyze your heart from a close distance. There's obviously interesting issues that what if someone hacks your cell phone? There's the ability to take those chips like in the brain and put them on the retina. There are clinical trials that are taking patients who are blind and allowing them to see basic things. They can make basic letters, basic shapes through implanted microarrays on their retina, and that's going to get better and more in reality. People are working on sort of assisted living contact lenses, so you can see your environment a little bit more. Maybe that's going to change your behavior a little bit. If you can see how many calories you're eating, you might change that up a little bit. Again, integrating visual devices with mobile is coming down, not just for potentially looking at an ear, but looking at microscopic slides from various places in the world, and pulling that together with the era of microfluidics, which enables you to take what used to be done on multiple tubes with a big lab that can be done on a very small chip at a very low price. And obviously take these to places where you don't have laboratories in most cases. Eventually, these things are going to get smaller and smaller to the era of nanotechnology or nanomedicine, the ability to build devices at the molecular level. While these are still on the drawing board, they're quite theoretically possible, where we'll have smaller and smaller microbots that are going to kind of move through your system and clean your clots and arteries. I'll finish up with two things, exponentially cheaper. So a really significant area, obviously, in medicine or problem is higher costs, but some things are getting cheaper, particularly in the era of genomics and genomic sequencing. It was 10, 11 years ago that the first genome was basically sequenced. It took about 7 years. It took over $1 billion. That price point has been falling at basically a double exponential, more than about 5 times in terms of price and performance and speed. So it's not any cheaper, it's faster. And we're really, just as of last week, several companies have said, well, you put us a credit card in for $5,000, we'll not only sequence your credit card, your genome, we'll put it on a disk, and we'll help you analyze it. So that price point is coming down, and I think if we have this meeting back here in, let's say, 2 to 3 years, and Raymond's an expert on this, we'll basically be at the $100 type genome in your hand, or maybe even eventually free. So just like you pay for your cell phone service, maybe you're just going to pay for analysis of your genome, and those will be given away. So we heard just in the last talk, 2 talks about personalized medicine, which is really an important area, and genomics is really associated with that because we really want to get to the right drug for the right person at the right time, and that really doesn't happen today. Lots of companies are evolved in this space, and you can start to take genetic information and understand risk a bit better, but the idea is really to get to the right drug to the right person. I can look at my 3 genes, for example, that relate to my dosing for Coumadin, so pharmacogenomics is probably the most obvious utility for this today. You don't need to be sequenced. You can do this analysis for about $200-300 today and already get this data yourself. So that's going to change what drugs you pick and what doses you pick. And together with all this other information, becomes really relevant. Again, I mentioned we're at the era of too much information. How do we pull this together? The era of systems medicine, systems biology is trying to pull that together so we can make sense of this and be what in this era of what's called P4 medicine. So we'll be predictive. You know what genes you have. You know what you're likely to get. You can then take preventative steps that are aligned with what you have. That prevention can be personalized to you. And finally, the big P that's emerging now is participatory. We can take your data and share it with others in your family. Other people have similar diseases. There's several companies like Patients Like Me who allow people to share their clinical experiences and what drugs they're on. Cure Together is another local company that's working on, if you have migraines, you know, what works for you and finding other people like you. Microsoft Health Vault allows you to put your data up there and share it, for example, and mine that data potentially. So as we start to crowdsource that, that's going to become more and more relevant. The problem for the poor doctor like me is what do you do with all that? Not only do you have all this data from your patients, maybe coming from their Fitbit or their home events, you have paper publications that are going up, you know, a number every year. So the complexity of modern American medicine exceeds the capability of the unaided human mind. What do we do to make this information useful? Even in dosing a simple, relatively simple drug like Coumadin, there's at least 7 different SNPs or types of genes involved, all sorts of different information about what you might use to tweak that, and it's not something you can keep in your head. So I'm just recently started a company that's looking how to pull all this together and eventually build your own personalized pills out of that. So I'll skip that to go to the last part, which is where we really want to go, which is exponentially better. So medicine today still isn't often that effective. We treat high blood pressure, hypertension with drugs. A local company called Ardian is just sold for like $1 billion after they developed a simple device that could go into the kidney and knock out the nervous supply to your kidney, and that can knock out the signals that often cause hypertension. So a single procedure is basically curative in a large population of patients with hypertension. So that might be a better way of treating hypertension. In terms of oncology, as we just heard, and I'm trained in pediatric hematology oncology, we're mostly treating every cancer the same. They often come back. If you think of cancer as a weed, if we can find the cancer stem cells, which we're identifying at Stanford and other places, we can go after the right, but what now is the wrong target. We sort of weed whack away most of the tumor. We think it's gone and it comes back. But if we can start to identify what's called the cancer stem cell, we can then go for longer term cures. And I think this is opening the era of personalized oncology. The motif, I think, will be in 5 or 10 years that every tumor is sequenced, because it'll be $1,000 or less. You'll get not only the genomic data, but the proteomic data from those tumors. We'll be able to look at those and figure out what's the right, what pathways are involved, what drugs would be most appropriate for that individual patient, and come up with a cocktail like we do in treating infectious disease. And that's sort of the era of personalized oncology that the press two speakers are touching upon, both in imaging and in diagnostics, to really make individualized cocktails. Another local company that's been a game changer is Genomic Health. They will take patients with breast cancer, analyze a few genes, and say whether that patient is really high risk or low risk, and they can save a lot of women who would normally have gone through chemotherapy, the risk and cost and downsides from doing that. The last bit I'll mention, I'm way over time, sorry, is regenerative medicine. That's a really exciting area that I've been mostly focused in the lab and clinically. We use adult stem cells today in bone marrow transplantation. We're using adult stem cells now in a whole range of applications. Embryonic stem cells are just entering the clinic as of last year. We've been using adult stem cells from marrow to treat, using orthopedics, heart disease, vascular disease. In Europe, actually, the pioneers in Europe have been in the Netherlands and in Germany treating patients with heart attacks with their own marrow-derived cells, and you can get much better outcomes in terms of survival and heart function if you take the patient's own cells and treat them that way. And that's still in clinical trials, not being really reimbursed yet. During my introduction was mentioned this device called the marrow miner, and just really briefly, I came up with a better way of, instead of poking the hip 100 times to pull out bone marrow, basically a device that would do that once and travel through the marrow cavity. You can see in the little X-ray in a patient, and take what used to be an operating room-based procedure and take it outpatient and make it faster and more effective. And finally, where things are getting really exciting in personalized medicine intersecting with stem cell biology is the ability to make your own personalized stem cells, and that's the era of iPS cells. We can take basically 4 regulatory genes, reprogram a skin cell, and make that essentially the equivalent to an embryonic stem cell and push that to become heart muscle or nervous tissue or beta islet cells. And again, it's only been about 4 years since these were sort of discovered. They're not really in the clinic yet, but we're at the cusp of being able to make your own bank of tissues that you can freeze away or use to treat a particular disease, and maybe even make your own personalized stem cell bank, which eventually will be integrated with 3D printing, the ability to take tissues and engineering together, eventually print, for example, your own heart with a variety of things. Still sort of out there, but integration of multiple technologies together. So I will skip this and just say that I think where things are getting exciting is the integration of smaller devices, personalization, decentralization, and by putting these together, I think it's a really exciting era to innovate, despite the FDA. And if you start to think and start to appreciate where things are going on these exponential trends, we can move to an era where really the patient is more involved with their own care, participatory medicine, so the doctor is, and the patient are more empowered, that we actually move the curve to the left, we enhance prevention and wellness, and we treat patients and discover disease really before they're at that sort of stage 3 and 4, what I call stage 0 medicine. We cure people essentially before they get sick. So I'll stop there, and thanks.